Hello, everyone. This is Dr. Mike Chua, physical therapist. Hey, today we've got a special guest, Dr. Dona Kim Murphey. We'll be back in a few seconds. Okay. All right. If I can make this work.
HelloNote is a truly therapist-friendly practice management solution with integrated EMR that will enhance workflow, efficiency, and patient care. HelloNote reduces error and allows you to spend more time with your patients. It comes integrated with billing. Claims are generated once a note is completed. You can bill with one click and a patient portal, which streamlines the patient intake process. Beautifully engineered and cloud-based for easy accessibility, the software works on all platforms. You can access patient records from anywhere. We also offer 24/7 support. HelloNote is the practice management solution that you're looking for.
Well, hello, my Facebook friends. If you're watching live, comment live. Watching on the replay, comment replay. I think we are live. I think I'm sharing it to our group now and everything. But we got a special guest for tonight. Her name is Dr. Dona Kim Murphey. All right. So she's actually a neurologist, ladies and gentlemen. So let's go ahead and do this. So we've been, teaching, mentoring, guiding, moderating our Alzheimer's and dementia support group. And we got several people there that will reach out to us and, hey, can we help you and guide you? And then out of nowhere, a neurologist reached out to me. Well, how can we say no to that, right? Well, anyway, she is a Korean American neurologist. We're gonna ask her, what is she doing here in as a neurologist? She's also a neuroscientist. Oh gosh, neuroscientist. We're gonna ask her what is scientist, right? A combination of fancy words like her, and promotora. We're gonna ask her what is a promotora too, right? Maybe something to do about promotion, right? In Houston, Texas. All right. With over 10, I'm running out of English, doctor, 10,000 hours of community service, organizing experience at the intersection of race, immigration, poverty, and health. We need this now. We really need this now. And thank you for answering the call. But many are called, but few are chosen. She's one of the called one. The called one. She was called, and she's also chosen. She's actually motivated by three Korean speaking grandparents with dementia. She asked me to actually the other day, hey, have you been hit by, Alzheimer's and dementia? I said, yeah, my dad had MCI. My aunt just died of vascular dementia. And then, she, by three Korean speaking grandparents with dementia and her 31-fold risk of this disease, right? This lady is so smart. She is very fluent in Spanish and, of course, English and rudimentary Korean. Stop being so humble. Rudimentary, right? Without further ado, let's go ahead and bring in Dr. Dona Kim. Dr. Dona, again, could you please tell us again who you are? I know I introduced you like crazy, but what are we doing here? Tell us, teach us, tell us about you first, and then after that, tell us about your experience with Alzheimer's and dementia.
Sure. I am a neurologist, as you mentioned, and then also a promotora, which is the Spanish word for community health worker here in the greater Houston area, supporting caregivers, people living with dementia, here and also outside of greater Houston, but primarily here. We're all kind of struggling in the moment with the impacts of Hurricane Beryl. So I'm here joining you from a coffee shop this afternoon. I think about 2 million of us still don't have electricity, and that's been really difficult for people who already have a very difficult time managing their loved ones at home who have this condition. But I've been very committed for the last couple of years, especially explicitly, to supporting family caregivers of people living with dementia. And that comes from a very personal place for me because I've been so impacted through the family members who've had dementia, a couple of whom have passed, one of whom is still with us. My mother is the primary caregiver for her mother, or my grandmother, who has mild dementia. I don't think I mentioned to you that my father also has mild cognitive impairment. So we're kind of working through all of that now. They also are without electricity. And, you know, these emergency situations for families who have family members with dementia can be particularly challenging. So we've been reaching out all afternoon to try to make sure that those families are supported in the special needs that they have, but also in the general needs that they have, because they're particularly vulnerable, especially with the heat being as high as it is here in Houston these last few days without any air conditioning. But yeah, I don't know if we have any specific questions. I know that I had collected a couple if we have no current questions coming in.
Yeah, but thank you again, Dr. Don. I appreciate you. You got some fans shouting out there. I think Anlan Nguyen. What's up, Anlan? She said, yeah, go Dr. Donna. There you go. And then one of your friend, yes, Queen. That's definitely for Dr. Donna, not me. I can be a queen too. Sometimes my wife, thinks I'm a queen. It's like, yeah, stop whining. You're such a queen. So anyway, I got a good friend too, Antonio. Thank you, Antonio. Kumusta lakay? How's everything? And how's everything there back home? Well, anyway, Dr. Donna, let's go ahead. I know we're streaming this live also in our Alzheimer's and dementia support group to support, the people with Alzheimer's and dementia. You mentioned it already. Since we're in this, situation right now that you have, it's very imperative that we have some sort of protocol for people who have Alzheimer's and dementia when we don't have power. And when we don't have power, people with Alzheimer's and dementia, they go and they do a routine. They have to have a regular routine. If their routine is messed up, they're gonna their cognition level, their confusion will get worse. So, is there any tips that you can advise for us, Dr. Donna, about that?
Yes. First of all, if I'd like to share a resource with everyone. It's one that I shared with all of our family caregivers this afternoon. I don't know if I can type it to folks, but I can state it out loud. It's tinyurl, tinyurl.com/dementia disaster.
tinyurl.com slash
Backslash
dementia.
dementia disaster. It's not a resource that I created. It's one that was created by the ACL, which is
Can
that
you say that
acronym
again?
stands for
tinyurl.com slash dementia.
dementia disaster.
Dementia disaster.
Yes, and this is a resource. This is a resource prepared by the Administration for Community Living, as well as a couple of other organizations. It's an emergency preparedness toolkit for people living with dementia. So it doesn't just pertain, obviously, to the current disaster, the wake of the current disaster, which is Hurricane Beryl here in Houston, but pertains to any disaster, whether that is a fire, a tornado, man-made disasters, right? Forced displacement because of conflicts. There are so many different things that create emergency situations for families, and often the last people we think of are the people who are most vulnerable, like those who are living with dementia. These situations are stressful for those of us who don't even have dementia, right? So you can imagine that people who are already confused at baseline and disoriented, that it would be particularly stressful for them. So this guide is really nice in that it helps you to think about these things in advance so you can be proactive, right? Because in many places, it is possible or even likely that at some point you're going to have to deal with an emergency situation. And this can be even in an emergency that's just particular to you, maybe like a house fire or something like that, right? So making plans in advance for how to ensure that your loved one is cared for, and you have a plan for evacuating them safely, and also just tending to their specific kinds of needs as a person living with this disease. In this kind of stressful environment, I think it becomes even more difficult to communicate with our loved ones. There are lots of tips specifically on how first responders, as well as us within the family, I mean, we are a kind of first responder as well, can navigate that situation, communicate with someone who is in distress. And this is actually, I think these are good tips in general, because often we don't know exactly what is bothering our loved ones who have this disease, and learning these communication strategies can be very helpful just every day, right? And also, like, how can we mitigate or lessen some of the acting out, the behavioral symptoms we might see in these stressful circumstances as much as possible. It's of course best to not disrupt the daily routine. So I know that some people right now, they're not in their own homes because they don't have air conditioning. There are cooling centers all around town. So they're displaced, even if they are coming back to their homes to sleep at night. The temperature does, get to the 70s. So it is possible to sleep in your own home without air conditioning at night. But during the day, many people are having to go elsewhere, right? So it's like, how can you try to establish somewhat of a routine in this new environment? Routine is so important for people who are living with dementia. And then also recognizing that the disruption to sleep, not just for our loved ones, but for ourselves, can really undermine like our ability to deal with stress. I think having some grace about that for our loved ones and ourselves, and trying to minimize the amount of disruption as much as that's possible as well. I know that there are lots of people who are stepping up in our community to offer their homes as places where you can go to potentially to stay overnight, certainly to go during the day. And it's nice if you can kind of go repeatedly to the same place again to kind of establish a routine in the immediate aftermath of something like this. Yeah, so there are lots of tips there I think that are really useful, but also a lot of helpful advice on how to be prepared in the first place, because so many of us, I think, are not even thinking of these things until they happen.
Amazing. Well, thank you for sharing that. I think I'm gonna have to probably print this out and also create, have it as a downloadable form in our clinic, because for those people who are watching, go check out this website, tinyurl.com/dementia disaster. It's basically emergency preparedness toolkit for people living with dementia. And I'm gonna share my screen. So is that okay, Dr. Donna? I'll share my
Sure.
screen a little bit about this PDF that you just shared. Uh, See, it's well, I gotta start sharing. So it's basically 40 pages, ladies and gentlemen. That the resources from Dr. Donna. I mean, of course, she said it's not from her, but it's for everybody to check it out. So basically, we all need this. If failure to plan, if you plan to fail to plan. Is that how you say it, Dr. Donna? So um, it's basically a toolkit that you can read, and of course, towards the end of the toolkit, I was just reading on it earlier. There are like, where is it at? Somewhere here. You know, emergency information that you guys can, get. Your neighbor's number, your emergency contact, alternate your paid caregiver, out of town contacts. It's very important that you have this. In that way, you have it already in your emergency toolkit, and then boom, at least you're prepared. Right, Dr. Donna?
Exactly. So you're not having to scramble last minute. You have a plan in place for when this happens to you.
True. Again, it's tinyurl.com/dementia disaster. I'm gonna have that also downloadable in our website. It's 40 pages. It's a lot to print out, but it's good. It's a good resource for our patients too. So we do home visits too, and we also do patients in our clinic. So, Dr. Donna, could you please tell us again? I mean, most common questions that we receive. What is the difference between Alzheimer's and dementia? Of course, I will have to explain it again and again, but we want to hear it from a neurologist. So what is the difference between the two?
Sure. So dementia is kind of the umbrella category of diseases that are the result of brain cells that are dying over time. So there are many different conditions that are considered dementias. Alzheimer's is the most common kind of dementia. So not all dementias are Alzheimer's, but Alzheimer's is dementia, if that makes sense. Um, and Alzheimer's is, particular in that it is often marked by memory loss, trouble remembering words, trouble remembering things that happened recently, what you ate for lunch, what you wore yesterday, things like that. And the other dementias may have that as well, but there are some other defining features classically for some of those other kinds of dementia. So it's helpful, I think, for somebody academically to really know the difference for research purposes. Sometimes we're treating some of the symptoms. The only drugs that we have to slow down the progression of disease, and there are no drugs to actually stop dementia or reverse dementia, any of the dementias. The only drugs that we have that definitively slow the progression down of any dementia are for Alzheimer's dementia. And there is some evidence that those same drugs that were developed first for Alzheimer's can be helpful in some of the other dementias as well. But the evidence is not as robust because they were not originally trials done for those other dementias, right? So yeah, I mean, because Alzheimer's is the most common, impacting about 60 to 80% of everybody who has dementia, that's the one we focus on disproportionately. Which means probably that those of us who are in this work should talk a little bit about the other kinds of dementia too, because they get neglected, I think. And there are certainly large numbers of people who are dealing with those other types as well.
That's true. That's true. Thank you for explaining that again, Dr. Donna. Again, for those people who are watching live, comment live, watching on the replay, comment replay. And then if you got any questions, yes, you may be replying towards the replay or the recording of this show or podcast. She will answer back. But I got a question here, Dr. Donna. I posted it in our group. And the question here is, my husband has been having visual problems for 2 or 3 years of his diagnosis of 5 years. I saw something about posterior cognitive atrophy on the page, and she thinks he is a victim, but he was probably 73 when it started. It makes me feel validated to read about it and think that someone out there understand. He has problems seeing what is in front of him. So I guess she just explained it to me. So, can you tell us more about that? I mean, especially when it's the posterior lobe of your brain. Is it really connected to the vision? Is it the frontal lobe connected to executive function? Could you tell us more different parts of the brain that it gets affected?
Sure. So this is one of the dementias that is not super common. We're not totally sure, actually, if it is its own thing or if it's somehow related to Alzheimer's disease. I think the first thing to maybe address is the question that you asked, which is the symptoms themselves that have to do with visual changes. Are they coming from the eye? Are they coming from the brain? So in this case, if somebody has this, right, that is diagnosed, it's visible on brain imaging. It is something that is happening in the brain. Our vision, of course, relies on information that comes through our eyes. And there are elements of the nervous system at the back of the eye that are part of the eye, but they are connected to the brain, namely this posterior part of the brain. That is the first kind of processing center of vision in the brain. So yeah, people who have atrophy, and atrophy is basically another way to say, like, you can see on a brain imaging scan the loss of the brain cells from that particular part of the brain. So I don't know, what else did you ask about this? Or did I answer the questions that you had about it? Uh-oh, I can't hear you now.
Yeah, there you go. I was muted, so it's probably my wife who wants to just mute me when I'm talking. That's just kidding. I love my wife. So yeah, she was asking about that posterior cognitive atrophy. So for those, I can't say the name, obviously, of the person who sent me the message, but generally, ladies and gentlemen, if you're watching, different parts of your brain has different function. Dr. Donna mentioned it. The front part is your executive function. Right over here, your temporal. What is it closer to other parts of your organ? It's your ears, right? So if you have a temporal atrophy, you could have some hearing problems, either a hearing hallucination or whatever. What do you call that when you have hearing hallucination? No, it's not hallucination.
Auditory
Auditory hallucination. So of course, the back of your occipital lobe affects your vision. So if that part of your brain has atrophied, like what Dr. Donna was talking, it will affect your vision. You could have visual hallucination. So she mentioned about, is it really the eyes or is it the posterior lobe that is affected? So you have to really go to a good neurologist to really assess what is causing this. Is it just because of the eyes? Sometimes, it could be just the eyeglasses. I go to the nursing home and I would just clean their eyeglasses. Just random day. I will just go, hey, I'm here to clean your eyeglasses. They'll be like, oh, I can see now just because of the cleaning that. Check your loved one's eyeglasses. Half of the time, or half of the time, 100% of the time, they have what you call bifocals, and their eyeglasses are like kind of crooked. And then imagine you're doing this. It's gonna be hard. I have bifocals here, and it's gonna be hard. I'm already kind of double vision here. I could have, I could see something. So we gotta fix that, first, the eyeglasses, fix that. Their posture, are they leaning forward like this? Do they have kyphosis? If they have kyphosis and they have bifocals, and their bifocals is somewhere at the bottom, how can they see it? So they're seeing from the top of the eyeglasses, and they cannot use their eyeglasses anymore. So those stuff like that. So you got to go to a good neurologist to assess that, postural and neurological assessment. Dr. Donna, do you have any questions there on your end? I gotta dig into some questions
Um,
here.
yeah, so I had some questions actually. I posted earlier this week, or maybe last week, on social media, asking people who follow me or friends of mine if they had questions. One that commonly came up in this request for questions was about heritability. So a lot of people ask this question. Obviously, family caregivers of people living with dementia are related to the people who have dementia and have concerns about heritability, right? Because we have the intimate experience of seeing what this disease looks like over time, and it's pretty devastating to the person who is, living with the condition as well as the person caring for them. Many of us don't want to do that to the people in our lives, right? Like to become that kind of a charge for them. And so we're very interested, obviously, in what we can do to make sure that doesn't happen, in fact, of getting this disease. I will say that if you have a first or second degree relative, so a parent, sibling, that is a first degree relative, a second degree relative would be like a grandparent, your likelihood genetically is going to be a little bit stronger than a person who's further removed. Now, that is not super strong. It's not like the genetic risk that you would have if you have a kind of dementia that is actually that results actually in a dementia, in dementia symptoms showing up in maybe your 30s or 40s or 50s, and shows up every generation. That kind of dementia, obviously, if that runs in your family, that's a very different kind of risk. The overwhelming majority of people do not have that risk. They do not have that history in their family, so we don't have to worry about that. That's more of a kind of definitive thing, like it's going to happen, right? But for the overwhelming majority of us who end up getting dementia, it's something that there is a little bit of heritable risk for, again, a little bit more if we have people closer to us who have the disease, but it is very largely behavioral risk. So these are things like obesity. This is often related to high blood pressure, diabetes,
Why are
high
you looking at me,
cholesterol.
Dr. Donna, when you said obesity? Just kidding.
I'm not looking at you. Um, you're projecting, maybe. I don't know, but no. I mean, another risk factor is like lack of physical activity, right? Which I've often at different points in my life been very bad about. I think a lot of us are, especially living in the hot climates where it's difficult to get out regularly and exercise. It's more of a chore than anything else. It can be challenging to do that. And that, unfortunately, is also a risk factor. So we have to figure out ways around it, right? To make sure that we are regularly engaging in physical activity. Social isolation is a risk factor, right? That's also something that we can choose to do differently. And if we're more socially engaged, that's protective. Things like traumatic brain injury, which again, if we are, being preventative, like wearing a helmet when we ride a bicycle, wearing our seatbelt when we drive a car, being defensive drivers, right? All of the things that we can do to protect our heads during our lifetimes, that also will protect us from having dementia later on. And there are some things that are risk factors that we can't actually tackle individually. We have to kind of collectively make sure that policy protects us. So things like air pollution, that has been shown to have increased risk for the people who are in environments where there's like more particulate matter, like in the air, right, that they're breathing in. That gives you higher risk for stroke. It gives you higher risk for dementia. Less education also, that is correlated with higher risk for dementia. So all of these things are things that we can actually take action on, that will protect us, and really doing that from as early as we can in our lives, is really helpful. And certainly, for many of us, about 50% of us are actually middle-aged when we're taking care of loved ones with dementia, whether that be spouses, older spouses, or parents. We can start now. I mean, we can start even earlier than now, but I think in particular, we would be motivated to do it now because we're seeing what it means to have this disease.
So true. That's so true. I like what Dr. Donna mentioned about the risk factors. They're uncontrollable and controllable, and what she mentioned are obviously the controllable ones. Hypertension. If you have high blood pressure, just like me, yeah, Dr. Donna, stop looking at me. Got high blood pressure. The risk for getting vascular dementia increases when you get a stroke. She also mentioned obesity. If you're a little bit heavy on the heavy side like me, it's going to be difficult. You got all those high cholesterol levels, right? She also mentioned about exercising. Exercising is very important. It will solve a lot of problems in our healthcare issue. Of course, it's job stability for us, right? The more sick people are, it's we get more physical therapy clients. But if we have more people exercising, our lifestyle, there will be a lot of decrease in all these diseases. She also mentioned very important is the mental health. Depression, the 3 Ds that we always talk about: dementia, all right, depression. What's the other D, Dr. Donna? Dementia, depression, and delirium. Those 3 Ds, it's very important. That's why you need to have like friends and families that you need to talk to. And this one here, the education, she mentioned about it. It's very important that you educate yourself, because if not, you're just going to do what your previous family was doing, eating the same thing that they were eating, and then boom, you blame, oh, it's hereditary. No, you could have prevented it by preventing it, doing those reversible factors. So thanks, Dr. Donna, for explaining that. There's a
Yeah,
question here.
Oh,
Go
sorry,
ahead.
go ahead. Oh
Go
no,
ahead, Dr. Donna.
I just wanted to add, but thank you for actually mentioning depression. I didn't actually mention that, but I ordinarily do. It is definitely a risk factor. It's a little bit unique, and that is also, it is confused for dementia too. And when we make the diagnosis, the formal diagnosis of dementia, we actually have to rule out that the person has depression as the explanation for some of the symptoms, because it can look a lot like dementia sometimes. And so we need to make sure that that's not it. That often involves, if they have these symptoms that could be depression, it means treating those symptoms to see, is it depression? Does it get better with an antidepressant or some of the behavioral interventions that we use for depression? If it gets better, then that's not dementia. But if it doesn't get better, if it continues to worsen over time, then you have your answer. It's likely to be dementia. So it's both a risk factor and it can be confused for dementia. So it's a little bit distinct in that way. And then the other thing I wanted to mention is smoking and alcohol. Those things also will put you at greater risk for dementia. And sleeping also, I think, is really important to establish good sleep habits as much as we can, especially for our middle age, to protect our brains. Our brains have evolved to sleep for a reason. And so I'm very bad about this. So not maybe the best example, the model of it, but we should be mindful of that as well.
It's true. That's true. She mentioned about smoking. Of course, she looked at me, and drinking. She looked at me, and sleeping. Everything is like looking at me all the time. But anyway, sleeping is very important, ladies and gentlemen, because when you're sleeping, there's what you call sleep studies. The sleep doctors, they watch you while you're sleeping. They want to know if you're not breathing, because sleeping is very important. You got that. You need to have that oxygenation in your brain. You have sleep apnea, absence of breathing, and then you're not breathing. You're not oxygenating that brain. Guess what? You get dementia. She also mentioned about depression. You need to rule that out. If your loved one has, depression, and then it hasn't been treated, that needs to be treated first. In that way, you could really rule it out. Hey, is it really dementia and depression? And of course, we mentioned about what is that? I forgot again. Delirium. What are the causes of delirium? It could be UTI, infection, acute episode in recent surgery. They could have delirium, and you don't treat that infection. Then you could say, oh, it's just dementia. No, it's not. So you got to treat those acute episodes. Then you go to a neurologist. So this is a great question for you, Doc. It's actually for you, really. So the question is from one of our members here. How often do you take your loved one to see a neurologist? My mom originally saw for a diagnosis years ago. She had falls recently with some definite cognitive decline. She made an appointment with a neurologist and a geriatric doctor. Is the neurologist necessary, and will they do anything that a geriatric doctor couldn't/wouldn't? I'm wondering if I am just wasting my time. I'm not even sure what I'm wanting to know. I was just concerned about her decline. So I guess the question is it really worth it to see a neurologist if they're already seeing a geriatric doctor?
Yeah, so there are a number of specialists who deal with dementia ordinarily. And also, let me just say that there are primary care physicians or clinicians, they don't have to be physicians, that also actually have dementia patients and families who they will continue to follow over time. But often it is the case that there will be a specialist involved, at least for the diagnosis of the condition, sometimes also to follow the patients and their families. Those specialists will generally be a neurologist or a geriatrician or a geriatric psychiatrist. Within neurology, it might be a dementia specialist, it might be a general neurologist, just depending on their level of comfort with the disease and your level of comfort with them also, that you feel confident that they have addressed all of your concerns. I think over time, it's not crucial for you to be followed by those specialists. If you have a good relationship with them, if they're helpful to you, especially in connecting you to services and support, I think that that's always great for you to check in with them episodically. I do want to mention here that as of this summer, so starting right now, the Center for Medicare and Medicaid Services, CMS, has approved something called the GUIDE model, which through Medicare will pay for an annual visit with a specialist. So hopefully that's not a barrier to you getting that access to those individuals. That being said, it is still your decision at the end of the day whether you think that that is useful. I think it still could be, because as things happen, as the disease progresses, it might be helpful to check in every so often with that person to see, is there anything else that's going on that we can treat with medications, or that can, that we can address with connection to services, right, which they may have for you. That being said, that is not required. If it's really hard to mobilize your loved one, I think as this disease goes on, it's really a matter of being connected to the right support even outside of the medical system, right? So those are health and social services largely. This is part of the work that we do at Prognosis, which is a company that I started a couple of years ago to do this work. We offer free and low cost support to family caregivers, being mindful that the costs are enormous with this disease, right? The health, social, and economic costs. And so we want to be able to provide that kind of information that doesn't require a doctor per se, right? So that as your loved one is advancing in this journey with this disease and you are walking right beside them, you have someone's really, because it is a community of not just our community team, myself being a part of that community team, but also other caregivers. And right now we're we're predominantly in Houston, Harris County. So the idea is to be place-based. When we start to expand to other cities, then you'll have people actually from your community. But you're welcome to join our community for now, even though we're largely in this area of the country. But it's important to find those resources that are not necessarily doctors as well.
That's true. That's true. Speaking of resources, ladies and gentlemen, if you have a family member, if you are a caregiver right now, or you're experiencing all this situation, you also go to the Kubler-Ross stages of grief, right? Both you and the patient, you the caregiver, and of course the your loved ones. You go to the denial stage, you go to the anger or humor stage, wherein they're going to be angry because you're trying to say something. So when they're in the anger stage, you got to make sure you ask them like a close-ended question, like a yes or no question, instead of asking them an open-ended question, like what do you want to eat for breakfast? Of course, in their brain, they're going to process that what question, and guess what? They're going to just get upset. So it's very important that you as a caregiver, you got to change how you approach your loved ones, because most of the time, it's your approach to them that causes their behaviors, most of the time. Because for example, you're a caregiver and your arms are crossed like this, or your arms are on your waist, or your eyebrows are like this, and they see that too, and they can get agitated too. So there's another question here, Dr. Donna. I know you're very busy, so let's make the
No, no,
most out
I'm
of here.
I'm here. Hopefully, we can make this a weekly occurrence if there's enough interest. Yeah.
We just want to thank her, right? There's no power in her place right now, and there's like a whatever you call that. It's not a tornado, right? Or
A
it's
hurricane. It was a
hurricane.
hurricane.
They don't
Yeah.
have power, and now she's in a cafe. So thank you for doing this, Doctor. Now your commitment for doing this. So going back to the question, uh, the question here: her mom scored 8 on the MMSE. For those people who don't know, MMSE is mini mental status exam. Last July, I'm running out of English, Doctor Donna. The neurologist said she was in her final stage, which would last about 2 years. Mom is very mobile and good physical health. She's 79, and you would never know she has Alzheimer's. Over the last month, her cognition seems better. She seems more aware. She's more coherently, again, able to do full sentences without lapses. She's using her utensils more. Has anybody? Do you have any patients like that scored low, and then they're pretty, like this, able to move around and eat well and everything like that? Oops.
Yeah, so I want to talk about stages for a second here. I think that a lot of us get really concerned about what the stage of the condition is. Usually, stages are most useful, I think, for us to understand like when you can intervene in a disease. They're used in clinical research. They're also used for us to kind of track where a person is so that we can make sure that people are connected to the right supports, right? But what can be tricky about them is that they're not exact. And depending on whether it's a good day or a bad day, you might be in one stage versus another stage. There can be fluctuation depending on whether somebody has a concurrent illness, right? That might just be an infection, might be COVID, right? That makes them look pretty bad for that period of time that they have the infection. But they can then bounce back a little bit. It may be the case that they don't bounce all the way back to where they were after a big assault like COVID, for instance. Especially the earlier versions of COVID were pretty devastating. Obviously, a lot of people died from that version of the disease. But yeah, you can have decline after an infection like that. But also you can see people bounce back and kind of bounce up and down, just depending on what's going on at that point of their lives. And so I don't think we should get too consumed by that staging. I also think it's really not possible for us to predict, the person is in this stage, and so they have a certain number of years left. I mean, really, just depending on the person's other conditions, health conditions, and just the things that happen to them over time. It could be 5 years, it could be 10 years, it could be 20 years that somebody, lives with dementia. So it's really difficult to say. Now, one thing I will say is true is that if you have reached a stage where, having this disease, you no longer move, you no longer speak, you can no longer feed yourself, you can no longer go to the bathroom on your own, right? If it's that advanced, you will not bounce back to walking, remembering everything, speaking fluidly. That will not happen. But it is very possible that you kind of go, back and forth between like mild and moderate for a while. You may go back and forth. And then, over a longer period of time, the condition is likely to advance, right? Same thing, like that transition between moderate to severe disease. You might kind of bounce back and forth. So I wouldn't put too much stock in that. It's kind of a general picture of what's going on from our perspective as people who are caregivers or support caregivers, family members, right? It's not particularly useful, in other words, other than to just kind of have a general idea of like, where are we at? But it doesn't tell us definitively, like how many years do we have left, things like that. Yeah, I hope that's helpful, that answer.
That's so true. That's so true. Again, thank you very much, Dr. Donna. So again, on that same note, we talked about that Kubler-Ross. Sometimes your patient or your loved one will be in their denial stage. Sometimes they'll be anger stage. Sometimes they'll be bargaining. When they go to the doctor, they're all dressed up, and then at home they're like, "Oh, I don't want to do anything. I don't even want to take a bath." And then one day they're depressed, and one day they're accepted the situation. Now here's the thing, like what Dr. Donna was saying: if your patient or your loved one is jumping back and forth, one day they're depressed, one day they're denial, one day they're angry. There's something going on, like what she said. It could be UTI, it could be pneumonia, it could be infection, it could be COVID. We'll never know. So again, don't. Yes, the staging is important, mild, moderate, stuff like that. It's important for clinicians like us to identify, to document. But you, as the caregiver, the primary caregiver, you have to know. Oh, okay, today she's happy. What made her happy? Is she well hydrated? Or did she eat well? Did she take her, protein drink enough? And then the following day, oh gosh, she's having behaviors, but apparently she just forgot to drink. She's dehydrated now. So hydration is very important. Remember, your brain floats in water in CSF, cerebrospinal fluid. If you're dehydrated, what happens to the brain? It shrinks, right? So it's shrinking of the brain. It's Alzheimer's. So it's very important that you hydrate your loved ones. Okay, hydration. Okay, Dr. Donna, do you have any other questions there on your end that you want to share too?
Yeah, I want to emphasize, thank you for mentioning that it's important to make sure that, these other things are not the cause for somebody worsening like acutely in this moment, right? Something that I think we don't get told, and it's so important for those of us who are caring for people living with dementia, is that this thing is generally gradual change, right? Now, you do have a little bit of bouncing, kind of depending on like whether it's a bad day or a good day. Some of that is explained by things that are treatable, right? As Mike mentioned to us. And that's important to be able to identify. So if we're seeing somebody, gradually worsen over a period of many months or even years, and like on one day, they're suddenly much worse, that really should clue us in that something might be happening that we can treat, right? And from my perspective, I think we are trying to prolong quality life, right? And to decrease suffering for everyone. And, when somebody has a UTI and is acutely much more confused than they are ordinarily, right, that causes distress in our loved ones and suffering. And I think it's important to treat that. So we want to make sure that we're not ignoring that and just attributing that to dementia. Dementia, again, is generally something that is very gradual change over time. So if they're very different suddenly, be aware that can be like a pneumonia or a UTI. Something is going on that's a bit different, and that might warrant a trip to the ER, for instance, or at least a call to the doctor. Yeah, I just want people to be mindful of that. I don't have the questions in front of me, Mike, that some of the other folks left.
I got hundreds of questions, doctor. So
Okay.
let's do one more before I let you go. Okay, let's make the most out of it. We'll end at 45-minute mark. So there's one question here. My mom is nonstop picking her skin. She's on Zoloft. We've gone from 25 to 100. She said it's not helping. She has sores that are going to get infected. I just don't know what else to do. I know it's a medication thing she has to go to, but as a general precaution, what can they do on that?
Oh gosh. Yeah, I mean, I think I'm not sure that what the relationship is here between the fact that she is on Zoloft and she is picking her skin, and but we can see these kinds of like behaviors that can be injury to self, right, or self-injurious behaviors. Um, so I think the first thing to do often when they're doing something like that is to investigate like whether there is something that is causing them distress. Like maybe it is that they have dry skin, right? So then you want to inspect the skin to make sure there's something that there's nothing there that you're missing. Maybe you want to put some lotion on to make sure that there is nothing that is physically bothering them, that it's causing to engage in that kind of behavior. Um, I often hear, I will say, like, I don't have all the answers. And a lot of the um, expertise, I think, comes from lived experience. I often look to other caregivers to see what are all of the different strategies they've tried to address some of the challenges that I'm seeing with my loved one, right? Which is what I think is so beneficial, being part of these groups on Facebook, for instance, being a part of our caregiver communities also, because you can check in with them and ask these same questions live with community health worker who's trained in dementia, who also has their own perspective to offer and experience to offer. So I don't know. I mean, I bounce that question back to you, Mike, to say like, what have you seen works in this situation?
That's a great question, Dr. Donna. So first, like what she said, it's very important that you check. And I mean, you increase the medication Zoloft. What are the common side effects of Zoloft? I mean, dryness of the mouth, maybe diarrhea. So if the patient is having diarrhea, you increase the medication from 25 to 100. Well, guess what? She can have diarrhea and then dry skin, stuff like that. So, like what you said, identify the root cause. Or she's really having some visual hallucination. Is she seeing some sort of ants there? It could be your eyes, it could be your eyeglasses, dirt there or something. So hydration is very important. So if you increase them to 22 from 25 to 100, that's significant. That's more than double. The side effect is going to be you know magnified. So you have to really go back to your doctor, not just over a Facebook question. So, but go back to your neurologist, go back to your PCP, and then have them figure out. She could really benefit from it, but maybe she's just dehydrated. So stuff like
Mhm.
that. All right. Again, thank you, Dr. Donna. Appreciate you. I hope we can do this regularly. We really need this for our group. And where can they find you? But before where can they can find you, any last parting wisdom for the caregivers out there? Any special tip? Probably 2 tips for them, and then where can they find you, and then website and everything like that. So
Yeah, I mean, something that I've noticed is that very few of us realize that it is enormously beneficial to actually um, connect with other caregivers who are going through the same thing at the same time. Even more so if it's people going through it in the same place, because I think you have kind of a shared sense of like what local or place-based services and supports there are that you can share with one another. But I think even people who are going through it at the same time, right? The same thing at the same time, it's really valuable to connect with each other, because so much of this is just feelings of isolation and abandonment that we can resolve by connecting. And I think that community is really, really important. People just don't give it enough value. I think until you connect with other people, you don't realize actually how nourishing it is to be in community with other people, so that you can figure things out together, support each other, right? Like provide each other moral support, but also like logistical support. Uh, or support in terms of resources, right? Resource references. So I encourage people to engage in that, to join us, if that's the way you want to do it, but also to plug into these communities online, like the one that Mike helps to moderate. It's really fabulous. So yeah, thank you very much. And you can reach out to me on any of the social media that I have on Facebook. We're also on Instagram, Prognosis on Instagram, on TikTok, any of those places. You can go directly to our website, which is prognosis.com with a US for us together.
what can you tell us more about Prognosis? I mean, I know it's different color and everything. Tell us more about what is Prognosis all about.
Sure. So the word obviously is from the word prognosis with an IS, spelled with an IS, and that word means basically what is this condition going to look like over time, right? Like what can I expect over time? Sometimes people use that word to suggest, like, you know, how long you have with the disease, right? What is the projected end date of the disease, right? It's the demise of the person who's living with it. But we wanted to use it to say that, like, this journey is really defined by how we work together to basically get through it. What happens depends on us, and how we can support each other, like in that journey together. So yeah, that was kind of the inspiration for the name. And what we are is it's a tech-enabled platform, meaning we use technology to connect caregivers to other caregivers of people living with dementia. So family members, that can be chosen family as well, who are caring for people living with this disease. We try to do that in a place-based way. Like I said, we're mostly in Houston, Harris County right now, but we welcome anyone from across the country. In fact, also across the globe. We speak Spanish and Korean as well as English in the materials that we produce. And actually on our website, we do have caregiver stories that are in those languages as well as in Chinese, so in simplified and traditional Chinese. And yeah, you can search that library of stories. Those are the same kinds of stories, honestly, that get shared in our community spaces that are facilitated by community health workers like myself. We have community health workers who are from communities that are disproportionately impacted by this disease. So our team is mostly African American. We have Latina as well on our team. I speak Spanish, but I'm Korean American. So we're all there to support our caregivers. I think that they honestly are experts, you know, in the care of their loved ones, and they share that expertise with one another, and it's so powerful. So that's what we do weekly. We join together with our caregivers on a Zoom call, and we support each other. And then, like I said, you can listen to our caregiver story library, which is very extensive. It's searchable, it's vetted, so you don't have to worry about information sharing there that is, you know, misinformed. And then we also, for those people who don't yet have a diagnosis but are waiting to be seen, because sometimes that can take some time, or for some reason it's inaccessible for them to get the expert guidance they need, though we strongly encourage to try to connect to that expertise in order to get a formal diagnosis. For many reasons, it's really important. In the meantime, we do actually provide a screening and staging tool on our website that is free, that you can use. It only takes a few minutes to complete each of those assessments. And it will be actually an educational tool for you to understand what might be the explanation for your loved one's symptoms. It gives you an explanation there, depending on how you answer the questions. And that will help you to hopefully be a better health advocate for your loved one as you try to pursue a formal diagnosis. And it will give you some idea of what's happening so you can manage the issues at home in the meantime.
Well, again, thank you very much, Dr. Donna. Appreciate you. But before I let you go, ladies and gentlemen, all right, always remember the word FAST, F-A-S-T. Letter F, find people that will bring out the best in you, because you are the average of the 5 people you hang out with. So who you hang out with, that's going to be you. So same thing when you're looking for a neurologist or a physician, you know, find those people who will, you know, bring out the best in you. Okay. Same thing with caregiving. You know, if you hang out with those caregivers who always complain, well, guess what? You're going to be ending complaining too, right? You know, hang out in the barber shop. You're going to eventually get a haircut. So I think I need a haircut, right, Dr. D? So find those people that will bring out the best in you. Next letter is letter A, take action. All this stuff that we're doing, it's not going to do me good. It's not even going to do Dr. Donna good if you don't take action. Take action by going to her website or Prognosis Instagram page or whatever, you know, YouTube page. I'm running out of F, Dr. D. So take action. You know, if you already have a loved one that has Alzheimer's or dementia, take action. You know, it's imperfect action beats perfect inaction. If you already have signs, go to their website. There's like a free app that you can use. You know, just do a screen. You know, there's a difference between a full-blown evaluation and a quick screen for your loved ones. A quick screen, you can identify, okay, there's some symptoms, you know, showing of this. So it's very important that you take action. Next letter is letter S. Share and subscribe. The more shares, the better. Share Prognosis It's a good it's a group group. So prognose us, right? So what does prognosis means? I ask her, right? So basically asking, hey, what is it? A good prognosis, a fair, a bad, a poor, something like that. We do that with our patients. Hey, what's the prognosis of stuff like that? So I'm sure prognosis for Dr. D is a good prognosis for your loved ones. Okay. Last letter is letter T in the word fast is letter T is teach it. Why? Because when you hear it, you forget. When you see it, you remember. But when you're actually teaching it, just like what Dr. Donna is doing, she's teaching us, the more you're understanding it more. So same thing with you. If your loved one has some sort of a Alzheimer's or dementia, teach other people about that. Hey, awareness is the key. So if your loved one has Alzheimer's or dementia, tell the rest of. I'm not saying announce it to the whole world, right? But educate the people. Join your Alzheimer's association. Be your Alzheimer's group there in your local area. In that way, the more attention, the more awareness, the more you get attention to it. Oh, okay. Hopefully, we can find a treatment or to prevent this. So maybe the next episode we can talk about different medications on the next episode. Again, thank you very much, Dr. D. Any last parting wisdom for them? Are we good?
Oh
I
gosh.
think you're ready to go. She's ready to go.
Feel free to reach out. Sorry, feel free to reach out. I'm always available, and I love to be helpful to people who are going through this because I know that it's difficult for my family. It's been difficult for me to just be a part of that, like intimately experiencing what it is to witness this kind of decline over time. So yeah, feel free to reach out.
All right. Well, again, thank you very much. Be awesome, be great, be excellent. And we'll see you in the next episode of the, we can call it Prognosis Show. All right. I'll see you around, ladies and gentlemen.
Thanks.